If you take blood pressure medication, there is something critically important that most patients are never told the day they fill their first prescription. It is not about which medication you are taking. Most people have at least had that conversation with their doctor. And it is not about diet or lifestyle. Most patients hear a version of that guidance as well. What almost never comes up in the 10 or 15 minutes a standard appointment allows is this: when you take your medication may matter just as much as what you take. The timing of blood pressure medication is not a minor administrative detail. It is not something you can ignore and assume the medication will manage on its own. The wrong timing can silently reduce the effectiveness of your treatment. It can leave your heart and kidneys exposed during the most dangerous hours of the day. And in some cases, a single timing habit repeated daily without realizing it is a problem can undo much of what the medication was designed to accomplish. I have watched this play out in my clinic repeatedly. Patients doing everything they were instructed to do, taking the correct medication at the correct dose, attending follow-up appointments, monitoring their numbers at home, and still struggling with unstable readings, unexpected dizziness, or complications that seem to have no clear explanation. When we worked backward through the details, timing was at least part of the answer more often than most people expect. Today I am going to walk you through the 5 most dangerous timing mistakes in blood pressure medication use. These are the mistakes that most physicians never get the chance to fully address in a brief appointment. The ones your pharmacist should have walked you through when you first filled the prescription, but often cannot because of time constraints. And the ones that can accumulate into real health consequences over months and years of daily use. If you take a water pill in the afternoon or evening, I need you to hear mistake number 3. If you take a calcium channel blocker and you eat grapefruit or drink grapefruit juice, mistake number 2 is going to change your morning routine. And if you have ever missed a dose and taken 2 the next time to compensate, stay with me because the answer is not what most people assume. Let's begin. Mistake number 1 involves the most widely prescribed class of blood pressure medications available today, ACE inhibitors and ARBs. Drugs like lisinopril, ramipril, losartan, and valsartan are taken by tens of millions of patients daily. For decades, the standard patient instruction has been consistent: take it once in the morning. That recommendation was practical. Most people have an established morning routine. It is easy to remember alongside breakfast or a glass of water. But that instruction was based largely on convenience and convention, not on the most current clinical research. Here is what that research has uncovered. Your blood pressure is not a flat line throughout the day. It follows a natural rhythm. During sleep, blood pressure typically drops, sometimes by 10 to 20% in a healthy cardiovascular system. Then, in the early morning hours, usually between 4 and 8 a.m., it rises sharply as the body prepares for waking. This rise is called the morning surge, and it represents one of the highest risk windows for cardiovascular events in the entire day. Heart attacks, strokes, and sudden cardiac deaths occur disproportionately during this window. Now consider what happens with timing. A medication taken first thing in the morning peaks in effectiveness during the daytime hours. But by the time the dangerous early morning surge arrives the following day, that medication's concentration in the bloodstream may have already declined. A medication taken at bedtime, by contrast, is still at or near its peak during exactly that high-risk window. Several large clinical studies have examined this directly. Patients who shifted their blood pressure medications to bedtime dosing showed better overnight blood pressure control, and in some analyses, significantly reduced rates of major cardiovascular events compared to patients taking the same medications in the morning. I want to be honest about the state of the evidence here. Not every study has found the same result. The benefit of bedtime dosing is more clearly established for some medications than others, and your individual blood pressure pattern matters. This is not a change you should make on your own based on this video, but it is a question you absolutely should bring to your physician. Ask directly, should I be taking my blood pressure medication at bedtime instead of in the morning? And can you explain which timing is better for my specific case? If your doctor has a clear reason for your current schedule, that is ideal. If this is the first time the question has come up, that is equally valuable information. Mistake number 2 surprises almost every patient who hears it for the first time because it involves something that seems entirely unrelated to heart medication: grapefruit. If you are taking a calcium channel blocker for your blood pressure, a class that includes medications like amlodipine, nifedipine, and felodipine, then grapefruit and grapefruit juice represent a clinically meaningful interaction that many patients are never clearly warned about. Here is the mechanism. Grapefruit contains natural compounds called furanocoumarins. When consumed, these compounds inhibit an enzyme in the digestive tract called CYP3A4. This enzyme is responsible for metabolizing and processing a wide range of medications, including most calcium channel blockers. When CYP3A4 is blocked, your body cannot break down the drug at its normal rate. As a result, the medication accumulates in the bloodstream at concentrations that can be significantly higher than what was prescribed. In practical terms, your standard dose of medication may behave like a much larger dose. Blood pressure can fall suddenly and severely. The resulting symptoms include dizziness, lightheadedness, flushing, a racing heartbeat, and in some cases, dangerous cardiac arrhythmias. This is not a theoretical risk. These are the kinds of symptoms that bring patients to emergency departments, and the grapefruit interaction is not always on the list of possibilities being considered. What makes this especially important to understand is the duration of the effect. A single serving of grapefruit or grapefruit juice can suppress CYP3A4 activity for anywhere from 24 to 72 hours after consumption. That means the grapefruit juice you drank on Monday morning may still be affecting how your body processes your Tuesday medication. The interaction does not reset between meals or even between days. Not every calcium channel blocker is equally affected, and individual responses vary. But do not assume your specific medication is safe without confirming it directly. Call your pharmacist and ask one specific question: is grapefruit a concern with the calcium channel blocker I am currently taking? That phone call takes 5 minutes and could prevent a genuinely dangerous interaction that has been silently affecting your treatment. Mistake number 3 is the one I encounter most frequently in clinical practice, and it is also one of the most preventable. It involves diuretics, commonly called water pills, one of the most widely used medication classes for blood pressure management. Drugs like hydrochlorothiazide, chlorthalidone, and furosemide work by helping the kidneys remove excess fluid from the body, reducing blood volume, and lowering the pressure on artery walls. The timing problem is simple and common. Many patients take their diuretic in the late afternoon or evening, sometimes because they forgot the morning dose and took it when they remembered, sometimes because they were never clearly instructed that time of day matters specifically for this medication class, and sometimes because a twice-daily regimen was prescribed without a specific cutoff time being communicated. The predictable result is exactly what you would expect. The medication works as intended. It promotes fluid elimination. But it does so at night, pulling the patient out of bed multiple times between midnight and 5 a.m. Most patients accept this as an unavoidable side effect of the medication. Many live with it for years, assuming it is either normal or untreatable. It is neither. It is a predictable consequence of incorrect timing, and it can be corrected with one scheduling adjustment. But I want you to understand what the real consequence of this pattern is beyond disrupted sleep. Every time an older adult wakes at 2 or 3 in the morning, rises from bed quickly in a dark room, sometimes disoriented from deep sleep, with blood pressure that can drop suddenly upon standing, the fall risk increases significantly. This is not a small concern. Falls in adults over 70 are among the leading causes of injury-related death in the United States. Hip fractures in patients over 70 carry a 1-year mortality rate of 20 to 30%. A timing mistake that takes 30 seconds to correct is contributing to that risk every single night it goes unaddressed. The rule I give every patient is clear. Diuretics should be taken in the morning, no later than 10 a.m., so that the peak effect occurs during the day. If you are prescribed a twice-daily diuretic, the second dose must be taken no later than 2 p.m. Getting this far into a video like this tells me something about you. It tells me you are not looking for the quick answer. You are looking for the right one. This channel exists for adults over 50 who understand that real health decisions, especially ones involving daily medication, deserve complete information, not the abbreviated version designed for a 15-minute appointment. Here is what I see happen consistently. Someone watches a video like this, finds it genuinely useful, and closes the tab. 2 weeks later, they cannot find the channel again. If what you are hearing today is changing how you think about your blood pressure medication, do not let this conversation disappear. Tap subscribe right now. New videos every single week. Stay with us. Mistake number 4 involves a combination that is nearly universal among the patients I see in practice. Beta blockers taken alongside morning coffee. This class of medication, which includes metoprolol, atenolol, carvedilol, and propranolol, is prescribed for both blood pressure control and a range of cardiac conditions. The overwhelming majority of patients who take them do so in the morning, often at the same moment or within minutes of their first cup of coffee. Here is what is happening physiologically when that combination occurs. Caffeine activates the sympathetic nervous system. It increases heart rate, temporarily elevates blood pressure, and essentially signals the cardiovascular system to speed up. Beta blockers work on the same system but in the opposite direction. They block sympathetic nervous system activation, slow the heart rate, reduce the force of cardiac contractions, and lower blood pressure. Taking these two substances simultaneously is something like pressing the accelerator and the brake at the same time in the same vehicle. For most patients, the medication's effect dominates, and no serious clinical harm results from this overlap. But for patients with a known history of cardiac arrhythmias, the 30 to 60-minute window following caffeine consumption, when caffeine reaches peak concentration in the bloodstream, can increase the likelihood of palpitations or irregular heart rhythms, even in the presence of a beta blocker. The medication blunts but does not always fully suppress the arrhythmia-triggering potential of a caffeine surge in a vulnerable cardiac system. There is also evidence that caffeine may influence the metabolism of certain beta blockers, particularly metoprolol, in individuals with specific genetic variations affecting the enzymes that process the drug. This is not clinically relevant for every patient, but it does mean the interaction can carry more significance for some individuals than for others. My recommendation is straightforward. If you are taking a beta blocker, allow at least 30 to 45 minutes between taking your medication and consuming your first coffee. This is a small and easily manageable adjustment. For most patients, it changes nothing. For patients managing arrhythmias or difficult to control blood pressure, it may be one of the most useful timing adjustments they can make. Mistake number 5 is one I want to address with particular care, because the instinct behind it is completely understandable. A patient misses their morning blood pressure medication. They remember at noon, at 3 in the afternoon, or sitting down to dinner. The thought that follows is almost always the same. I will take 2 tonight to catch up. The logic seems sound. 1 missed plus 1 extra equals 2 doses, which is exactly the prescribed total. But blood pressure medications do not balance themselves out over time the way that arithmetic suggests. For several important medication classes, including calcium channel blockers, certain ARBs, and beta blockers, taking twice the intended dose creates a rapid and potentially severe drop in blood pressure. In a healthy younger adult, this might produce uncomfortable dizziness and lightheadedness for several hours. In an older adult whose vascular system has reduced elasticity and whose blood pressure regulation is less responsive, the same drop can cause fainting. And a fall in a 72-year-old is not the same clinical event as a fall in a 30-year-old. There is a second variation of this problem that I find equally concerning in practice. Some patients who are prescribed twice daily blood pressure medications quietly consolidate to once daily use because it is easier to remember. They do not tell their physician. Their blood pressure readings at clinic appointments may look acceptable because those readings are taken during the day when the morning dose is still fully active. But their overnight and early morning cardiovascular protection is incomplete, and that is precisely the window where risk is highest. The correct guidance is this. If you miss a dose and you are still within the same day, take it as soon as you remember, unless you are within a few hours of your next scheduled dose, in which case skip the missed dose and continue your regular schedule. Never double up on your own. The right answer depends entirely on your specific medication, and your pharmacist can give you a precise answer in a 5-minute phone call. I want to tell you about a patient I will call Roy. Roy was 68 years old, a retired engineer from Ohio. He had been managing high blood pressure for 6 years and was on a combination of medications including hydrochlorothiazide, a diuretic. His numbers had been reasonably controlled for years. By most measures, his treatment was working. Roy came to see me because he had not slept properly in nearly 2 years. He was waking up 2 to 3 times every night to use the bathroom, spending significant time each morning trying to function on fragmented sleep, and had developed the kind of chronic fatigue that was beginning to affect his concentration, his mood, and his relationship with his wife. He had raised the nighttime urination with previous providers and had been told it was likely age-related or possibly related to his prostate. It had never once been traced back to his medication timing. When I reviewed the full details of his daily routine, the answer was visible in under a minute. Roy had been taking his hydrochlorothiazide at 6 in the evening with dinner because that was the most convenient time alongside his other evening medications. Nobody had ever explained to him that diuretics need to be taken in the morning. Nobody had asked him what time he was taking it. We made one adjustment: moved the hydrochlorothiazide to 8 in the morning. 1 week later, Roy called the office to report that he had slept through the night 4 nights in a row for the first time in 2 years. By his follow-up appointment 2 weeks later, the chronic fatigue had lifted substantially. He sat across from me and said with visible frustration and genuine relief in equal measure that he could not believe a 2-year problem had a 30-second solution. Roy's case is not exceptional. I have had versions of this exact conversation with many patients. The medication was right, the dose was right, the timing was never addressed because in most clinical settings, it simply never comes up. That is the gap this video exists to close. Before I close, I want to give you something specific and actionable. Because everything I have covered today is general medical education, and general education has its limits. Your physician has something I do not. Your complete medical history, your full list of medications, your documented blood pressure patterns over time, and the clinical judgment to apply all of that to your individual situation. I am not asking you to change your medication timing based on this video alone. What I am asking you to do is bring 5 specific questions to your next appointment. Question 1. Should I be taking my blood pressure medication at bedtime instead of in the morning? And can you tell me why one timing is preferable for my specific medication and my blood pressure pattern? Question 2. Are there any foods, beverages, or supplements I should avoid within a specific window around my dose? If I am taking a calcium channel blocker, should I be concerned about grapefruit? Question 3. What should I do specifically if I miss a dose? Is there a time window during which it is safe to take it late, or should I skip it and continue my normal schedule? Question 4. At what time of day is my blood pressure typically highest, and does my current medication schedule address that window? Question 5. Are there any timing interactions between my blood pressure medication and my other prescriptions, and is my current daily schedule optimized for both safety and effectiveness? These 5 questions require less than 3 minutes of appointment time. They open a conversation that most patients have never had. The answers, when they are specific to your medications and your medical history, can meaningfully improve the safety and the effectiveness of treatment you are already taking. Here is what I want you to carry forward from this conversation. Blood pressure medication works. The evidence supporting its use in managing hypertension is among the strongest and most consistent in all of cardiovascular medicine. Nothing I have shared today is a reason to stop taking your medication, modify your dose, or change your timing without first speaking to your physician or pharmacist. What I have shared is a reason to have a more complete conversation than most patients ever get the chance to have. Mistake number 1. Not asking whether bedtime dosing may better protect you during the morning blood pressure surge. Mistake number 2. Consuming grapefruit while on a calcium channel blocker and allowing an enzyme interaction to silently amplify your dose. Mistake number 3. Taking your diuretic too late in the day and accepting the resulting sleep disruption and fall risk as unavoidable. Mistake number 4. Taking your beta blocker and your morning coffee simultaneously without allowing a separation window, particularly if you have a history of arrhythmias. Mistake number 5. Doubling up on a missed dose rather than consulting your pharmacist for medication-specific guidance. Each of these is preventable. Each one is correctable, and not one of them requires a new prescription, a new medication, or a new physician. They require the right questions, asked clearly, in your next appointment. If someone in your life is managing blood pressure, share this with them. The 5 questions in the last section of this video are worth writing down and bringing to their next visit. I will see you in the next one.